Good morning. I'm Dr. Ara Duke-Majan, and we are here at the Duke Spine Institute getting ready to perform the first of 6 surgeries today. It is now April 13th, 2023. Our first surgery today that will be streaming live is a patient who has 3 herniated discs. You can see them on the MRI in the bottom corner of your screen. And she has neck pain, and it's radiating into her arms, from her neck down into her shoulders, down into the arms. So she has symptomatic disc disease. I simply call it disc disease because there's so many different names for disc disease: herniated disc, bulging disc, annular tear, ruptured disc, slip disc, protruding disc, extruded disc, degenerated disc, spondylosis. Those are all the same thing. They're a disc problem. And by the way, the disc is very simple. It's only got 2 parts, an annulus and a nucleus, so it can't be that complicated. But we make it complicated. The reality is the problem is with the disc, okay? So, thank you, Luis. Can you see this, Henry?
Yes, we can.
So we're going to start by showing you, this is a patient who's sterilely prepped and draped. This is real spine surgery. The patient's intubated. They have a tube coming out of their mouth. The mouth is here. There's a tube literally coming out of the mouth, going to a ventilator over here, and that tube goes down into their trachea. Their chin, the patient's chin is here, the eyes are here, the nose is here, and believe me, she's a lot better looking than that, but my artistic skills are not great. The middle of the neck, you can see the sternal notch is right here. So the middle of the neck is here, and we're going on her left side. The structures that I have to be careful about, there's many of them in the neck between the skin and the spine. You have the carotid sheath and the jugular vein, which run here, sternocleidomastoid muscle here, trachea and esophagus in the midline. So my goal is to get in to the spine, and since we're doing 3 discs today, we're doing number 4, 5, 5, 6, 6, 7. Everybody agree? We want to start over the middle disc. That means it's the center of the surgical field. Okay, the C5-6 disc is what I want to target. Upon entry, we're going to try to do all 3 discs with 1 incision. That incision will be 4 millimeters, and I'm going to fix 3 discs with one single 4 millimeter incision. That's the goal. Now, one of the reasons the patients are under general anesthesia is so that the muscles in the neck are relaxed. And when they're relaxed, they're like jelly. You can push on them and they don't contract back. If they're not relaxed and you push on them, they will literally tighten up and make the surgery impossible to do. That's why the patient has to be under general anesthesia for the surgery. Shot. All right, you can see the needle 2, 3, 4, 5, 6. I'm a little too low. I want to be slightly higher than I was. There we go. I walked up. You use 2 fingers and you go between those fingers. I'm using an 18 gauge spinal needle. Shot. There it is. 5, 6. 2, 3, 4, 5, 6. Perfect. Now let's get an AP. I want to make sure I'm in the midline. I can feel the spine with my fingertips, by the way, in case you're wondering. I'm literally touching her spine. Perfect. So we're almost exactly in the center. Are we broadcasting?
Of course.
All right, excellent. So you can see that on that picture also I displaced the trachea and esophagus. So 2, 3, 4, 5, 6. So I was a little high there. Let's go down just a little bit. When I say high, I mean north or superior. Shot. That's a little too inferior, but I'd rather be a little inferior than superior. Shot. All right, so that looks pretty good right there. 2, 3, 4, 5, 6. You agree, Luis? Jordan? Shot. Now I'm touching the spine, okay? You can see the tip of my needle touching the front of C6. I'm going to lift, slide north just a little bit, retouch, and we're in the front of the disc right there. It's perfect. I'm touching the ALL, anterior longitudinal ligament, AP. Let's see, make sure we're in the middle of the spine quickly. Shot. We are. Back to a lateral. So the needle tip is right in the center of the spine where you want to be. Shot. All right. I'm entering the annulus through the front. People ask me, when you enter the annulus through the front, doesn't that damage the disc? The answer is no, it doesn't. Because there are tissues in your body that can be spread apart. Shot. I've turned the needle a little bit. Shot. Shot, that should be good. Just do a little bit further. Shot. So I'm pretty much in the center of the disc with the needle tip. Show us the needle tip. Show us the center of the disc. That's correct. Now let's count. C2 is the tall bone. 3, 4, 5, 6. So we are at the 5-6 disc. We're going to fix 5-6, 4-5, 6-7, 3 discs. The one that the needle is in, and the one above and the one below. Those are the 3 that are causing her symptoms. We're going to start by doing a discogram. Now let's show the audience right there on the lateral view. Henry, let's go back to the x-ray. Let's show the audience the trachea, endotracheal tube. It has a linear line inside of it, so you can see it on x-ray, but that is the endotracheal tube. And let's show the esophageal probe. The esophageal probe is braided. It looks like a chain, okay? So you have a linear endotracheal tube and a braided esophageal temperature probe. Those 2 lines tell us where the trachea and esophagus are. So let's go back to the AP view. The AP view is going to show us the midline of the spine with the spinous processes. We're going to show you the spinous processes. It'll also show you the trachea and esophagus. Show us the spinous processes. There's one, there's one. So if you're near the spinous processes, you're in the middle of the disc. Show us the left and right extent of the disc. There you go, from there to there. That's the disc. And you can actually see the foramen. Show us the foramen on the other side. There, that little white thing. No, come to the right a little bit. To the other way. A little more. There, that's the neural foramen where the nerve leaves, right there. Okay, so we're going to stay there and we're going to do a discogram. Ready? Not getting much dye coming out. I wonder if the needle is full of some disc material. Yeah, I'm not able to get the dye to come out. Let's go back to a lateral view. Yeah. Yeah, go ahead. We're going to clean the center of the needle out because it may have some disc material stuck in it at the tip, in which case I can't push the dye out. So, all right, shot. Shot. Yeah, there's some junk in there. Shot. Shot. That should be it. Hopefully that does the trick and we can get our discogram done. Yeah, some discs have so much inflammation you just can't get a discogram done. And that may be the case we're dealing with. All right, well, we've done what we can. It's a mostly degenerated disc. I don't know if you have that, Henry, by the way. It's more of a degenerative disc disease. Did you shorten this? Guide wire? No. Shot? Just looks shorter than normal. Shot? All right, so the guide wire is in place. Now we're going to numb up the skin and we're going to do our incision. We're going to use a little bit of lidocaine and marcaine. We don't use epinephrine anymore. We discovered that it's increasing the blood pressure a little bit. We want to avoid that. All right, well, let me know once they have an idea of how much of that pain, where the X is. Incision, 4 millimeter incision. Now I'm going to take out the needle shot. Again, you're watching live surgery. We broadcast our surgeries live for a reason. Number one, we want you to be able to watch and ask questions during the surgery so I can answer them as I go along. And number two, the best way to learn surgery is to actually watch it live. And we don't edit anything. That way you know what you're watching is real. There's nothing that's been edited out or edited in. All right, so I'm in the front of the spine with the dilator tip. Show us the dilator tip, Coker, and then switch to a AP. Interesting. We will need some inline traction in a moment. Not yet. We're just localizing first. We want to make sure the dilator tip enters the annulus in the front in the middle. And it is. Show us the middle. There's the center of the spine, and the dilator tip is right there, just slightly a millimeter or two eccentric to the left. All right, lateral view. One of the nice things about this surgery is it's bloodless. Literally, we're going to lose, that's 2 drops of blood we've lost so far. And we're almost done with our exposure. The exposure is the part, little bit of traction. The exposure is the part of the surgery where you lose the most blood. All right, so I'm entering the annulus now. I'm going to take the guide wire out, and I'm going to advance my dilator through the disc all the way to the back where the herniation is. Shot. Now she has degenerative disc disease, for those of you wondering. Hold that. Shot. Huh, went away. You see that? That was the water. Irrigation, I should say. Boy, that is a collapsed disc. That's why. It's got a lot of scar tissue here. Are we giving inline? Yeah, she's got a severely degenerated disc here. I can't get that in any further. We're gonna have to just go with that. I may be able to, give me a little more inline. I'm not making any progress, so we're just, that's it. That's the limit of what we can get in. Let's hope that's enough. All right. Any questions from our audience? We're going to need a little more inline.
No current questions.
And are you sure that we are able to ask questions?
Yes, we are.
Excellent.
We do have a few comments. One from good morning, one thank you so much, and a comment saying, what a game changer. Your team does great work.
Thank you so much. All right, so the good thing is that we are able to get questions and comments. All right, let's see if I can just get it a little bit further. I'd like to be a little further back. Sometimes when you get the tube in, it actually opens the disc space a little bit more. I felt that go a little bit, no? Nothing significant. Just have to be careful because we're working above the spinal cord. We don't have any margin for error. Well, let's see what happens there. It may just be an angulation issue of the fluoro. It's nice that it's not lumbar, right? Yes. So let's show the audience real quick what we've got here. Henry. Can you guys see?
Yes, we can. Yes, yes.
So remember, she has 3 degenerated discs, and I believe they're causing her pain. They're irritating the nerve roots. So the treatment for this is to go to the back of the disc and remove the herniation, get rid of the inflammation in the annular tear. And that's what we're going to do, but we're doing it endoscopically rather than open. And by doing it endoscopically, we can avoid having to do a fusion. The whole surgery will be done through this 4mm tube. Let's go ahead and show our audience why do disc herniations, annular tears, why do they cause so much pain?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Hey, welcome back. But more importantly, that patient we're talking about, she has other issues besides her discs. She has SI. She has, why is this not turning? Interesting. She has ischial tuberosity tendonitis as well. All right, welcome back. You've seen what's happening in people's cervical spine with a herniated disc, why they have so much pain coming from the disc, and the reason is simple. Man, there's a lot of artifacts with the laser, you know, a lot of bright lights flashing. And the reason why people have so much pain coming from a disc is that there's an annulus, which is a connective tissue band located in the back of the disc, actually circumferentially around the disc. And the part in the back of the disc has special nerve fibers in it that basically, I guess it's a warning system for the brain that tells the person, hey, we got a problem. Yeah, it's really interesting. I never thought of it that way, but that's exactly what it is. It's a warning system. So the fibers of the annulus located on the sides of the disc and in the front of the disc do not have these sentinel fibers, these sentinel nerve fibers. And these sentinel nerve fibers we're talking about are actually somatic afferent nerve fibers, which project to the thalamus, and then from the thalamus up to the primary somatosensory cortex of the brain. And what that does is, by going to the primary somatosensory cortex of the brain, which, by the way, is located in the parietal lobe, just behind the central fissure. Man, this irrigation is cold. It's like freezing my hand. It's good stuff. By projecting to that area of your brain, there's something called the sensory homunculus, which is basically a representation of the human body in the brain surface. And it is a special part of your brain because it is the main area where the most important sensory information in your body goes to, okay? And because of this primary somatosensory cortex is specialized to allow the brain to localize pain, it allows you, the human being, to respond to painful stimuli in certain parts of your body. Now, everything you have in your body does not have this painful stimuli system. Okay, highly localized painful stimuli system. It's literally unique to certain organs and tissues. Skin, for example, has it. The back of the disc has it, but your organs do not have it for the most part. Your intestines don't have it. So when you have certain types of feelings in your intestines, like gas or whatever, you get a vague discomfort, okay? A vague discomfort. That vague discomfort is not localized. It doesn't tell you exactly one pinpoint spot where the pain is. It's a vague discomfort. And that's because the sensory neurons that go to the intestines project to a different part of your brain. They actually project to the subcortical regions within the brainstem, like the medulla oblongata, and areas in the pons. And basically, they don't make their way up to the primary somatosensory cortex, okay? So basically, these other pain signals called visceral afferents, they don't project to the primary somatosensory cortex. Therefore, your body doesn't localize that pain in those areas. Another example is muscles, right? So you all have muscle aches, but you don't have highly localized pain from muscles. It's just the whole muscle aches. Same thing with your belly, your intestines, when you have gas or something. It's just the whole belly aches, okay? So basically, there's two types of sensory systems, if you want to think about it, based on where they project to in the brain or brainstem. There are the highly localized system of pain, and there is the vague, not localized system of pain. And the sensory fibers that innervate the back of your discs, the posterior annulus, they're special. Now, nobody ever taught me this. I had to figure it out, okay? Because as a neurosurgeon, you learn about nerves and where they project, but nobody in the world has ever looked at the pain fibers in the back of a disc and whether they're somatic afferent or visceral afferent, because what that would require is something called tractography, which is basically following axons throughout the body. And the problem with tractography is that the dyes that are used to study projections of axons and neurons throughout the brain and throughout the body, well, they take a long time to diffuse along the axon. Some ridiculously small amount, like it takes a week to diffuse a millimeter or two, okay? So imagine you got to go from a disc in the lower back up to the brain. That's a years of movement. And the problem is nobody's ever done that to study it, to prove it. But it only makes sense physiologically that people with lower back pain that's highly localized to their disc or facet, those pain pathways project to the primary somatosensory cortex. And that's just what is called an assumption or a scientific presumption based on knowledge of the pathways that currently exist that we do have. And that's my theory. It's unproven at this time. It's only a theory, but it is a strong theory substantiated by my knowledge and understanding of the pain pathways that occur in the human body and the brain's function. As a neurosurgeon, we understand these things, okay? All right, so this is 5-6, and you can see the laser. It's covered in blue plastic until you get to the end where there's a little glass fiber poking out. And really, the laser fiber is a glass fiber. It's a standard optical relay fiber that's used. And it's the same type of fiber used to transmit internet overseas underneath the ocean. These sub-oceanic, subatlantic cables that are used for telecommunication are all glass fiber optic cables. All right, so far so good. A lot of chronic inflammation here and a lot of scar tissue. That's what all this white stuff is down here. That's why we could not get the dye to enter the disc. There's way too much scar tissue. So let's hope this helps. I think it will. I think this is going to really help her a lot, but you don't know until afterwards. I've never had it not work, so there's always going to be a first person that it doesn't work for. We've been doing this surgery 16 years. Now, people have other sources of pain, like their facet joints, but I've never had anyone where it didn't actually take care of the disc pain. So as long as you make the right diagnosis up front, and if you can determine the patient has disc pain, I'm pretty much done here. Let me just do one more shot at the side over here. Once you've determined the patient has discogenic pain, which is, by the way, 90% of neck pain, Once you've made that determination, the treatment is easy. It's the Duke laser disc repair. You could do a fusion as well, but why would you fuse somebody? It's far more invasive. So the treatment of discogenic pain is best treated with Duke laser disc repair. That targets the pain coming from the disc. There's a big bone spur right there that I'm taking out, by the way. The other option for discogenic pain, in my opinion, that works is a really good fusion as long as it incorporates all the discs that are problematic, not just one. Okay? You can actually see the nerve root, and I'm taking the bone spur off the nerve root. The nerve root is right here. The bone spur is right here. People ask me, can you use the laser to remove bone spurs? Yes. And just to give you an idea of how big these things are, that glass fiber right there, you guys see it at 12 o'clock? That glass fiber is 0.5 millimeter, 550 microns wide, okay? So that's how small these things are. That's how precise the laser really is, okay? It's very precise. A lot of scar tissue. All right, we're done with that level.
Lights on, please. Thank you.
Any questions?
Yes, we have 2 questions. This first one comes from Bill on Facebook.
Hello, Bill. Welcome to our live stream from Duke Spine Institute here in Florida.
And they ask, how long does the disc take to heal after surgery?
How long does the disc take to heal after surgery? Bill, it is a great question. The answer that I give everybody is 12 months. But the truth is that some discs are going to heal sooner and some discs are going to heal longer. But the longest is 12 months. So some people might be healed at 6 months, some people 9 months. If you ask me what the average would be, I would say 9 months. Now, does that mean your pain goes away in 9 months? No, the pain usually goes away immediately, like within a day, okay? But the disc has to heal. And the annulus fibrosus is the part that has to heal in the back of the disc, the annulus, okay? So it takes time for the annulus to heal. It takes a lot of time, unfortunately, because the annulus doesn't get a lot of blood supply. So tissues that don't get a lot of blood supply, like the annulus of the disc, well, they take a long time to heal. As a matter of fact, the annulus of the disc is the most poorly supplied tissue in your body. There's literally zero blood supply to the inner half of the annulus, the inner half, zero. So without any blood supply, how does the tissue survive? Well, it survives through diffusion. And diffusion is a process whereby nutrients are transmitted to that area through slow movement. Slow movement. It's through concentration gradients, basically. Shot? All right, so the tube is out. Tank's got. Right, Luis? Luis was holding his breath. I was holding my breath. All right. So just reshape that, but we're going to need more of those. I need you to find them, Luis. Okay? I don't care how you find them, find them. I need to be able to trust you to solve that problem. All right. So, are we ready? Yeah? All right. So let me just think, what were we talking about? The diffusion of nutrients. So to answer your question, we expect the disc to be fully healed, strong, capable, like it was when you were 18 years old before you injured your disc, at 9 months to 12 months post-op. All right, we won't take the other question yet. I've got to focus on what I'm doing, so just give me a minute. You don't need to flex the patient. I don't want flexion, that's for sure. Don't flex. Don't flex. When you're putting your hands, you're flexing. What you need to do is put your hands on the side and pull, not get under the head and pull, because when you go under the head, you're flexing. All right. So for right now, you can just relax. Once I get in front of the disc, then we'll worry about distraction. Can you guys see this here? So we have a 4 mm incision right there, Henry. Bam.
Yes, we see
All
it.
right. Shot. All right, I'm going to move this dilator. This is a technique that was developed at Duke Spine Institute by me 16 years ago. And the reason I developed this technique is because I decided a long time ago that people shouldn't have to have 2 or 3 surgeries if they have 2 or 3 herniated discs. But the people who taught me the surgery, the tube and the approach, the Koreans, and Sebastian Reuten in Germany, so a German surgeon, and a couple of Korean neurosurgeons, Dr. Sang-Ho Lee, Dr. Gun Choi, Dr. Sebastian Reuten from South Korea and Germany, they would only treat 1 disc at a time. And they would send the patient home, and a few months later they would do a 2nd disc, and a few months later a 3rd disc, okay? I decided I'm going to get them all done in 1 surgery. Is there a way to do it? So I developed the Duke Spine crawl, okay? Is there a better word for it? We're going to crawl to the next disc, all right? I'm going to show you how to do that. You don't need to do that. I'm going to first come out with the dilator, and as soon as I get to the edge of the disc, the front part, I'm going to let the tip come out and slide south, and I have to feel this. So if you can't feel your hands, do not do this kind of surgery. You have to have great feeling, okay? I could feel it come out. The second thing, step 2, once you get out, you keep the tip on the vertebral body. You keep it on the ALL in front of the vertebral body. Then I'm going to check my AP and make sure I'm in the middle. See that? I'm not in the middle. I'm a little bit to the patient's left. So I'm going to move the dilator tip slightly to the right. I have to stay on the vertebral body. That did not feel like it moved. Oh, it did. All right. Well, I moved a little too much. So how about that? That's perfect. See how the tip of the dilator is right where the spinous process is? Jordan, show them. The tip of the dilator is sitting on the front of the spine, dead center, right there. Okay, as long as you're lining up with the spinous process, you're fine. Now I'm going to go back to a lateral view, and I'm going to move my dilator down to the next disc, which this happens to be 6-7. Shot. And shot. I feel like I'm on top of the disc, yes. And I can feel it spongy. All right, shot, and then AP. Perfect, I'm right in the center. Now let's get an AP view. AP is front back. I want to make sure that I have not moved off to the side. Folks, if you're going to do this kind of surgery, you must. There we are, dead center. Show us. Show us with the arrow. See the spinous process right there? I'm literally over the spinous process. Now the spinous process is in the back of the spine. I'm in the front. But it's a reference point that tells us where the center of the spine is. Okay, any questions?
Yes, we have a question from.
I don't need distraction yet.
We have a question from Arida on
Who?
Arida.
Okay.
Arida on YouTube.
Aribe?
Aride. Apologies.
Is that Dr. Aribe?
I do
From
not know.
Tampa?
I don't know. Last
Okay.
name Danny Lova.
All right, very good.
And they asked, do you accept Medicare or TRICARE for life? Thank you.
Yes, we do accept Medicare at Duke Spine. However, Medicare will not pay for this Duke laser disc repair. There's something wrong with the injector. Is there? No? The Medicare will not pay for the Duke laser disc repair, guys. TRICARE used to pay. We went to battle with TRICARE because Humana, who runs TRICARE, doesn't want to pay. They want to save money. They don't want to pay for your medical care. So Humana tried to say no to the Duke laser disc repair, pipe cleaner. And Humana approved the Duke laser disc repair for years. We did over 20 surgeries on Humana TRICARE. And then after they approved the surgeries, they got the bill. And then they try to get out of paying the bill by saying, oh, the surgeries aren't necessary. They're not medically necessary. So we fought TRICARE, and we spent $100,000. There it is. You could see the tear, actually, just a second ago. Let's see if I can show you. Shot. Shot. All right. Well, the dye's leaking out through the tear. We spent over $100,000, like $150,000 in legal fees fighting them because they did what's called sham peer review, where they said it's not covered because it's not medically necessary. What they did was they hired some spine surgeons who lied and basically made up things and said, no, we shouldn't cover this. And then we called them on it, and they were misrepresenting the data in the literature. We brought that to court. The judge heard our case, and they ruled against TRICARE, and TRICARE had to pay for the surgery. But ever since then, now the military has said, okay, well, any surgery that doesn't have a Medicare value, we're not going to pay for. So it's approved, but we won't pay. It's basically shell games. The insurance companies are not your friends. The government is not your friend. The government spends literally billions of dollars on computer software called electronic medical records that do absolutely nothing to help patients at all. And it's been proven over and over again. They spend all these billions of dollars on software to make people rich, who then turn around and support politicians in their campaigns, like Epic, for example, or one of these other EMR systems. I worked at the VA system for years, 7 years, and they have a computer software system called Meditech, and it was perfect. There was nothing wrong with it. It kept great data, patient medications, all your tests you had, MRIs, X-rays, CTs. It had all the results in there. You could even pull up the diagnostic images on their PAC system. And I used that back in the 90s, and it was beautiful. It was like the best EMR system there was. So why did the VA need to go out and spend $5 billion on a new EMR system when they had the best EMR system in the world? And you know, they paid that $5 billion to private companies who then give kickbacks to the politicians who force the VA to basically buy that system. So it's a very corrupt system we live in, and TRICARE and Humana are extremely corrupt, and they're not interested in providing you the best medical care anymore. They're just interested in making money and profit off the American taxpayers and not providing the best medical care. That's why the United States has fallen to like number 35 worldwide in healthcare, because we've sold out. We've allowed corporations to basically take over healthcare, and they're just profiting off of taxpayer-funded plans, and the patients aren't getting the medical benefits they should, whether it's Medicare or TRICARE. So you guys are going to have to fight, because I'm going to tell you something. It's not just Duke laser disc repair they don't pay for. They've cut benefits over the years. If you look at physical therapy, right, 20 years ago, Medicare paid for as much physical therapy as every patient needed. If you had hip surgery, hip replacement, Medicare would pay for 100 physical therapy visits or more, as long as the doctor ordered it. Now they pay for 25 or 30 of them every year. So they've cut. That doesn't mean the cuts are good for you. They're bad for you. But they're saving money by cutting. And when the government saves money, it's not because the government saves money. It's because some private company convinced the government to let them manage the benefits and profit off of the savings. So basically, these companies like Blue Cross Blue Shield, Cigna, United, they are profiting by denying your surgeries and your treatments, your MRIs, your X-rays. They have created so much bureaucratic red tape for doctors and hospitals and MRI centers and therapists to get paid that we give up because we don't have the time and energy, and we don't get paid to fight them, by the way. Every time we have to fill out a form or do a letter of medical necessity, those forms take hours of time going through the chart, and they design it that way so that we have to spend our time, and it's not compensated. You don't get paid for that time. They specifically will not pay you for filling out forms. And they've created so many forms for us to fill out now, and spend hours and hours and hours every day trying to fill out forms just to get a patient to have their medication that's needed or a test that's needed. And the whole design, it's all by design to basically keep people from getting tests that will lead to treatments, okay? You guys are being bamboozled by your insurance, and you need to stand up and fight. And I'm just making you aware of it. But it's your problem, America, not my problem. It's your problem, and I'm not going to fix it for you. I'm going to make you aware of it. And you guys are going to have to go out there and do something about it. It's your corrupt politicians It's your corrupt government committees and leadership that's basically stealing your money and not giving you the best health care anymore. This started in the 80s with managed care organizations, and they weren't just managing their plans, they started managing the government plans, like Medicare, TRICARE. And TRICARE has been managed by Humana for many years now. They're so corrupt, they deny and basically they're the best at preventing patients from getting their medical care, the very best. And that's why the government keeps hiring them, because they're really good at saying no, but giving these bullshit reasons to say no, okay? So be aware of that, and you guys are gonna have to fight, okay? The fights these days, they're not on the battlefield anymore with swords and shields, but there are wars and battles going on, and you guys are being subjugated by these special interest companies like Humana, like politicians being paid off and compensated for allowing laws to be passed that allow insurance companies to deny treatments. And that should never happen, okay? When I started medicine, there was no such thing as an insurance company denying a neurosurgeon what they recommended for a patient. It was absolutely unheard of. Now, they were denying chiropractor treatment back then, but they weren't denying neurosurgical care. Now they're denying neurosurgical care almost 100% of the time. Not just for me, but for my colleagues. You should see the things that they're writing. They're very angry. And the American Medical Association, right now, their top agenda item is prior authorizations. Because prior authorizations are what we're talking about, getting it authorized. But the insurance companies don't just scam you on prior authorizations, they scam you after you get the authorization on payments. They actually will fight not to authorize the treatment, but then if you win and you get it authorized, you do the treatment, then they don't pay the bill. And they have other strategies like high copays, high deductibles, high co-insurance. I just went with my wife to get a procedure done for her. We have United Healthcare, and she had a minor procedure at a hospital, minor. And we had to pay $14,000 out of pocket for that minor procedure that took like an hour, not even an hour, and not even an invasive procedure, okay? So why is it that we're paying $14,000, which is the whole bill, by the way, and the United Healthcare pays nothing? And the only thing United Healthcare does is take the charge from $20,000, which the hospital charges, down to $14,000, and then we pay the $14,000 as the patient. So we are being scammed out of our health. And so don't get angry at me that your insurance doesn't pay for the best treatment in the world. Get angry at your government. Get angry at your politicians. Get angry at yourself for sitting around and doing nothing about it. Okay? Yeah, I'm angry at you for not doing anything about it. You better believe it. I've been watching this happen for 20 years, and I've been talking about it for 20 years. And I'm really upset with the American public for not doing anything about it. We have the most corrupt government in the world. The difference between America and other countries, third world countries, is the other countries don't try to hide it. They're actually, I respect them more because they're honest about it. They're like, yeah, we'll take bribes. But so do our politicians. They take bribes like crazy. Do you guys realize the tobacco industry spends $50 million a year lobbying in Washington, D.C. so they could keep selling cigarettes that kill our kids and give us lung cancer, emphysema, asthma, COPD, all those horrible things that come in infants. What is it called when the kids are born small and malnourished from their mom smoking cigarettes while they're pregnant? What is that called, Berndes? Huh? Failure to thrive? Yeah. Anyway, we have all these diseases from tobacco use in our country that's legal. We know it's bad. 70% increase in all types we have vaping. Yeah, 70% increase in asthma in kids with mothers who smoke during pregnancy. My point is, our government is bought, and it's bought by large corporations, and those corporations profit by taking money meant for you to pay doctors and hospitals, which is why hospitals are now struggling and going bankrupt. Watch the news. They're closing all around the country. They're in dire straits financially. They're closing their doors, okay? All this is because the insurance companies are diverting the money that you're paying them as premiums into their pockets as profits. Obama didn't make it any better, unfortunately, but that's the reality. This patient has Medicare, I believe, okay? Yet she's paid out of pocket for this surgery for good reason, because it's the best surgery in the world for a disc problem. Thank you. All right. Anyway, no, Medicare will not pay for this surgery at this time in 2023, but we're going to take the fight to Medicare. That's a bone spur, by the way. In case you didn't notice, I'm taking a bone spur out. You see that white thing? I've been working on it for a while. That's a bone spur out of the foramen on the right side. That's pinching on her nerve. Okay, the nerve root is literally just below that. You guys see the nerve root right down here? That's the nerve root, and there's the bone spur. So people ask me, Dr. Duke, can you take bone spurs out with laser? Absolutely. It's the best way to take bone spurs, the safest way to take bone spur. Folks, that laser fiber is 0.5 millimeter. So imagine how precise I am being right now with this laser. If the whole width of the fiber is 0.5 millimeter, I'm taking out less than 0.5 millimeter. I'm taking out about 1/10 of a millimeter at a time, okay? Questions?
Yes, we have a question from Gadam on YouTube. And they asked, can you tell me, please, if I reside in Illinois, can you do surgery on us, or my insurance will not cover it if I want to do surgery in a different state with different doctors?
I don't know if your insurance will cover it or not. That's not for me to decide. That's for your insurance to decide. We just had to talk about that. If your insurance doesn't cover your surgery, then you need to fight your insurance to get them to cover it. It's as simple as that, okay? So if insurance doesn't cover surgery, fight your insurance to get them to pay for it. That's my advice to you. The way you fight your insurance is in court. In court. You're going to have to take them to court. The only way I see insurances agreeing to pay for surgeries that they don't want to pay for, or treatment they don't want to pay for, is take them to court. Okay, there's one other way, and that's to go to the local newspaper or the national news, and hopefully they'll be willing to pick up your story and make a big stink about it. And the insurance companies don't like that. They don't like a big national stink. All right? They don't like to be under the spotlight for doing bad things like they do all the time. So they always try to make it like the doctor's the bad guy. They love that experimental and investigational language on the denial, so it can look like it's Dr. Jekyll doing your surgery, experimenting on you. They love it. And it makes the doctor look like the bad one when they're doing the denial themselves. So patients buy into that. They eat into it because, you know, unfortunately, there's a lot of gullible people out there that believe whatever their insurance company tells them. My advice to you, do not compromise on your health, folks. You know, medical treatment, you should go for the best. Don't go for the one that is the cheapest. That's silly. If you're looking for a car or maybe a used bicycle to ride, you go for the cheapest. When you're looking for your health on your spine, don't go cheap. There's lots of things to go cheap on. You want a cheap steak? Go to the supermarket, look for the old stuff, have a cheap steak. You know? If you want cheap groceries, go to Aldi. But if you want the best quality, you go to the Duke Spine Institute. We're not the cheapest.
So we're like the Publix.
We're like Publix? No, we're like Whole Foods. Yeah. But Publix is very successful. It's one of the most successful privately held companies in the United States, as a matter of fact. It's still, I think it's still privately held, yeah. Publix is a success story. I go to Publix. Oh, really? Is Fresh Market part of Publix?
No, but it's a little bit of a spin-off of Whole Foods.
I see. Yeah, well, you know Amazon owns Whole Foods, right?
Oh yeah, that's right. They bought them, right?
Yeah, they bought Whole Foods years ago. Anyway, great questions, folks. I love it. I have no problem talking about insurance. I'm happy to talk about insurance. People think that I don't like to talk about the insurance problem, but I don't mind it. They think that the insurance problem is my fault, but it's not. The insurance problem is not my fault. It's your fault. And when I say you, I mean you are the one with the insurance. You chose it. It's like me, when I went to the hospital and I paid $14,000 out of pocket for my wife's surgery just a few weeks ago. I was shocked, to say the least, because I thought I had good insurance. But, you know, in the end, you have good insurance when your insurance pays for your treatment. You have bad insurance when they don't pay. It's that simple. So don't think you have good insurance when they don't pay, because you don't. And, you know, I have myself to blame because United Healthcare did not pay for my wife's surgery, basically. But we did it anyway because we knew it was the right surgery for her. So my point is simple. Don't blame your doctor when your insurance doesn't pay. Blame your insurance. Or if you want to blame anybody other than your insurance, blame yourself for picking that insurance. Okay? We're done.
Lights on, please.
Yeah, scope off, lights on. So we're done with the second disc, which is number 6-7. We're going to move to the third disc. I'm going to use a little antiseptic called betadine. Why don't you run the video, Henry, showing how does the Duke laser disc repair actually work in the cervical spine. I have no suction, guys. Hello, ladies, no suction. No suction on the, there we go, thank you. What happened? Did it come loose? Oh. I thought I would have to start sucking on it like a straw. Huh? Right? I'm just kidding. You know, surgeons can have a sense of humor and still do good work. All right, did you start the video?
Not yet. No, I will right now.
The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We're getting ready to transition to our third and final disc in the neck. We have already fixed number 5, 6, and 6, 7. If you look at the x-ray, you can count. Let's count. 2, 3, 4, 5, 6, 7. So we just finished 6, 7. We're getting ready to go up to number 4, 5. We've already done 5, 6. We're going to go to 4, 5. So to do that, I have to use the Duke slide. The Duke slide, spelled D-E-U-K, not D-U-K-E. Duke slide is in Duke Spine Institute. This is a technique developed here. Pay attention if you want to do this surgery. I recommend do not do this at home. But we're going to keep the dilator in position. We're going to wiggle the tube out. Get rid of the tube. And then now I've just got the dilator, right? Still no bleeding. There's the x-ray. You can see the dilator. Show us the dilator tip. The dilator tip is right there. Now we're going to come out of this 6, 7. We're going to move up 2 discs to 4, 5. You ready? Keep your eyes on the rabbit. Coming up. Shot. I'm just about out. I can feel it. Remember, when you come out, you cannot lift off the spine. You must stay. I'm out. All right, so I'm out, and as I move north, I want to stay in the middle. So you need to check shot, AP and lateral. Let's go to a lateral. I feel like I moved to the right a little bit, so I need to probably correct that before I go any further. Yep, I moved to the right a little bit, so I'm going to correct that, go back to the middle, shot. I'm feeling the bone spur in the front of the spine at C5-6 right now. Shot. I don't want to mess around too much, take my chances. I may actually pop back in the hole. Let's go to a lateral. So remember, there's an annular entry point where the fibers got spread at C5-6. And I'm right over it now, or very close to it. Okay, good. So we need to go up past 5-6. There we go, shot. All right, so we're in front of the number 5 bone. Let's count. 2, 3, 4, 5. So I'm sitting in front of the 5 vertebral body. I don't know if I'm to the left or right of center, so we need to check that. I'm going to use my coker so I don't radiate my hands too much. I don't want to have sarcomas of my joints. Ooh, anybody know what a sarcoma is? It's a horrible cancer of the soft tissues like muscle or even bones. And radiation is one of the most common causative agents, but it'd have to be pretty high dose over time. So it's good to avoid it.
You wear the lead gloves?
I wear leaded gloves, yeah. You see the black on underneath my gloves? That's lead. All right, shot. We're on top of the disc at 4-5. Now notice I can do all that just by feeling it. I can feel the tip. That's what neurosurgeons do. We feel our instruments. After years of doing neurosurgery, you can actually use your instrument like an extension of your finger. And the good surgeons can feel everything that they're touching through an instrument. It's really fine motions, you know, changes in texture, surface, elevation, and all that's done through feel. Okay, we are in front of number 4-5. We're going to enter through the anterior annulus, shot. I'm just gently tapping in, shot. And as I enter this annulus in the front, I want to verify that I'm not sliding to the side. Take AP, 2, 3, 4, 5. You want to make sure that you're not sliding because the front of the disc can be slippery. Nope, we're not sliding. So almost there. And again, this will be our third and final disc that we are repairing in this patient. What's next, folks? DPR room 2? Shot? Because we have so many surgeries today, 6 of them, we're going to shot. Yeah, there's a lot of junk in here. Shot. I think I got it out. Yeah, we got it out. Because we have 6 surgeries today, we're going to move 2 of our surgeries that are not going to be videoed, broadcasted into another room. Really hard to get any dye out. Oh, we got it. Good. I'm going to bring this to the back of the disc. We're not going to broadcast our Duke plasma rhizotomies because we just don't have time to do that. So I apologize in advance if you're hoping to watch that today. But we're going to, in the interest of time and safety for patients, we're going to forego the broadcast on 2 of our surgeries. They're both DPRs, Duke plasma rhizotomy. But I can tell you a little bit about them. Shot. What is the Duke plasma rhizotomy? Well, some of you have heard of a rhizotomy procedure. It's done with something called a radiofrequency ablation. There's other ways to do rhizotomies as well, like alcohol, chemicals. They can rhizotomize nerves with chemicals like glycerol. And we do this in just inline traction. Inline traction, everybody. We do the Duke plasma rhizotomy using a very high energy form delivered from a electrocautery unit. And as a result, we're able to get really good burning of the medial branch of the dorsal ramus, which is the nerve that goes to the facet joint. Distract, distract, distract. Almost there. A lot of scar tissue. Hold on, just give me a second. Almost there. Shot. Man, a lot of degenerative disc here. A lot of scar tissue in the posterior annulus. I can feel it. That's probably the best I can do. Thank you, everybody. Good work. All right, let's get this last disc done, number 4-5. Hold on. Make sure these tines are not pushed together too much or apart. Looks good. Hopefully that'll hold. These tubes must be created or purchased. Okay, Luis, that is your top priority.
Yes, sir.
I thought we had already worked out a solution. My engineer is not the solution necessarily. Okay, we need something reliable.
Yes, sir. Well, I have one, but
I don't care about the markings here. I just care about the actual tube.
No. But it just remember that we talked about 10,000 to do the reverse. Yeah, engineer.
Well, I want a total price to manufacture just the tubes. That's the most important thing. The scopes can all be repaired. All right, how are we doing there, Henry? Any questions?
Yes, we have a couple questions. This next one comes from Jay Mora on YouTube.
Hello, Jay. Welcome to our broadcast. Thank you, Oscar. Great job.
And they
Way to be attentive.
They,
Oops.
they asked, do you do workman's comp OWCP?
Do we do workman's comp? The answer is yes. As a matter of fact, work comp is one of the best insurers for the Duke laser disc repair because they, let me tell you why work comp, let me tell you guys the problem with insurance, okay? Workman's comp is very unique insurance. And what it does is if you get injured on the job, the work comp insurance, they call the work comp adjuster, work comp carrier, sorry, they have to pay for your injury for the rest of your life, okay? Remember that point. It's very, very important. By law, work comp insurance must pay for your injury for the rest of your life, okay? Remember that. If you, on the other hand, if you go and get Blue Cross Blue Shield or United Healthcare, they do not have to pay for your medical care the rest of your life. They only pay as long as you're paying them. And they know that. So they don't care about getting you the best care. Because you may have them one year and then you're going to change insurance and go with somebody else the next year. But work comp, you don't get away from. They're stuck with you. So they actually want the best surgery. Medicare does not want the best surgery. Medicare wants you to have bad surgery. Because if you have bad surgery, then you're going to tell all your friends you had bad surgery. And guess what? You're going to spread the news that spine surgery is bad. And they would love you to do that. Because then nobody's going to have spine surgery. They're not going to pay for your surgery. Because nobody wants it. Who wants to have surgery that's bad? So that's why Medicare only covers bad surgery, laminectomy, microdiscectomy, fusions. And they're trying to cut back on fusions, by the way. So Medicare and Blue Cross Blue Shield, United Healthcare, Aetna, Cigna, they all want only bad surgeries available for patients because they know those surgeries have a bad reputation and that patients are going to avoid them like the plague. Therefore, they don't have to tell you, no, we're not covering that surgery. They just know that you won't want a fusion, you won't want a laminectomy because they have a bad reputation, okay? So they let the reputation do their dirty work, which is the denial for treatment. All right. Now, when it comes to workman's comp, it's a different kind of insurance. They own that injury. So if you go and have a bad surgery, guess what? They're going to be paying for the next surgery because the bad one didn't work. So they're going to have to pay for the good surgery. So they're going to keep paying and paying and paying for the rest of your life for all your surgeries on your back or your neck. They don't want to do that. They want to get you fixed, which is why work comp pays for the Duke laser disc repair. They pay for it because they know it works and that they're not going to have to keep paying for more treatment for you afterwards. You see, the problem is when you get a fusion or a laminectomy, the insurance companies know that you're going to come back and get more surgery, for sure, and that you're going to get pain management as well. And you're going to spend quite literally millions of dollars over 20, 30, 40 years in treatment. But the thing is the Blue Cross and the Cigna and the United, they don't care because they're not necessarily going to be your insurance company next year. You're going to change to another company. But with work comp, they're stuck with you. They're stuck with your bills. They're stuck with the bad surgery results. They're stuck with the pain management. So they recognize the fact that Duke Spine guarantees and does great work, so they actually pay for the Duke laser disc repair. Now, some of them, sometimes you're going to get an adjuster who doesn't know what they're doing, and they'll deny it, okay? But work comp, for the most part, is smart enough to understand that this is a solution for people that have work injuries to get out of pain so that they don't have to keep getting treatments. So they love us. We get a lot of work comp. We have a lot of success with work comp, especially with the patients. Everybody talks badly about work comp patients. I don't. I don't because there's nothing bad to say, to be quite honest. In all my years of treating work comp, which is 20 years now, how many people have I seen faking their injuries? Almost none. Okay, maybe once in a while I'll see a faker. But everybody in work comp has legitimate injuries for the most part. And I don't think they're faking. I think they're real. And we've been able to cure their pain just like everybody else. To me, the work comp patients are some of the best because a lot of them, they're motivated to go back to work. They just want to get fixed. But unfortunately, most doctors can't fix them because they don't have the right technology to fix them. The right technology is the Duke laser disc repair that you're watching now, or the Duke plasma rhizotomy. And before there was a Duke laser disc repair, the right technology was fusion. And I can do a fusion on work comp patients and eliminate their pain. The key is you have to do all the levels that are symptomatic. Most doctors won't do that. The problem is most surgeons only fix one disc at a time. They know that the patient's going to come back again. They know that the patient's going to need another surgery. All right? So they end up just doing 5, 6, 7 surgeries on the patient. Me, I don't believe that's the right way to treat somebody. I believe the way you treat somebody is you do everything with one surgery and you fix everything that you can. Now, I'm not perfect. I can't do everything in one surgery. Sometimes we have to break it up, and sometimes they don't need a surgery. They need a pain management procedure, okay? But for the most part at Duke Spine, we're going to fix everything. If you give us the opportunity to do it, we're going to get it done. Great question about work comp. So yes, we take work comp. If you want more information about workman's comp, contact our work comp line. Henry, will you put that phone number in?
Copy that.
It's 321-775-8010. 8010. 321-775-8010. And you're going to talk to Becky and tell her, hey, I'm calling with a work comp injury out of whatever state you're in. Now, we have had some really good luck with some of our work comp patients from other states. Their adjusters will allow them to come here and get our Duke laser disc repair. Okay, so let's give it a try and see what kind of success we can have. All right, that's the foramen, by the way, the neural foramen on the right side at C4-5. You can see there's not much left in there. There's just a little bit right there, a piece of herniation wiggling its way out. One of the things the laser does that people don't appreciate is it actually jiggles It sends a pressure wave. It's known as a cavitation wave, and it literally mechanically shakes up the fragments of herniation. So it's literally the most perfect tool for this surgery. And the fact that, you know, doctors out there don't know what they're talking about and they badmouth the laser, it's only because they don't know. They've never used a laser. They're afraid of us. Us laser surgeons, they are truly afraid of us. Because we're taking their business away. And they don't like that. Patients are getting smarter. They're not just listening to their doctor and what their doctor tells them to do. They're going out researching and finding better ways to get treated rather than living in pain and suffering through treatments that don't work. They're actually going out there and discovering the best way to get treated. And they're coming across the Duke laser disc repair, which is the best way. People don't understand. I don't do the Duke laser disc repair because that's all I know how to do. I don't do the Duke laser disc repair because I just feel like doing it. I do the Duke laser disc repair because it truly is the best surgery in the world for a disc problem, a spinal disc problem. There is nothing better. I do all those. I've done all the fusions. I've done 1,000 ACDF fusions, 1,000 ACDFs and artificial discs. Hey, that's a lot of surgery, a lot of fusions. I'm not proud of it, but in the beginning, that's what I was taught from my university. I was taught to do fusions, okay? And that's what everybody was starting to do back in the early 2000s on artificial discs, same thing. And I was taught at the very best neurosurgery training program in the world at the time. I was recommended to go there by Dr. Marty Weiss, who I just reconnected with a few days ago. And Dr. Weiss is a professor emeritus and chairman emeritus at USC in Los Angeles, University of Southern California, Department of Neurosurgery. He's been succeeded by Dr. Stephen Giannotta. Dr. Weiss was my mentor in medical school. I was the valedictorian of my class. Dr. Weiss recognized my interest and talent, and he guided me to University of Florida in Gainesville to work and learn under Dr. Albert Roten, the former chairman who built that program. And he told me that Dr. Roten was the very best neurosurgeon in the country and that that was the best program to train in, best residency training program in the United States and the world. And that's why he wanted me to go there. And I went there. I turned down Hopkins, Harvard, Columbia, Yale, all those programs to train at University of Florida in Gainesville. And I don't have any regrets. I had very good training. More importantly, I met my wife there, and we've been very happily married now for over 20 years. She's my business partner, and she's far more than that. But long story short, it was actually my wife that got me to learn endoscopic spine surgery, because I had an opportunity to learn it by a rep who came to me and approached me and said, "You want to learn this technique?" And I said, "No, it's a joke. You know, I went to the very best neurosurgery training program in the world, and we didn't learn it there, so why would I want to go somewhere else and learn it? If it's not taught at UF in Gainesville, then it's garbage." Yeah, I had the same attitude that every other neurosurgeon has. And how wrong was I? But my wife told me, "You know what, just go. See what they're doing. Maybe you'll learn something." And I was like, "Sure, whatever." So I listened to her. And as a result, there's a herniation, by the way. I'm trying to cut this herniation in half because it won't fit out of the tube. So as a result of me going and watching these surgeries from these Korean doctors and German doctors, these pioneers in endoscopic spine surgery, I quickly learned that, my God, this actually works. At the time, they were only treating radiculopathy, which is nerve root compression, basically. And I was going in and learning how to do endoscopic surgery to decompress the nerve roots. But then I started to talk to my patients after the surgery, and I learned that not only did their arm symptom go away, but their neck pain went away. And at first I thought it was a bit of a fluke. Like, nah, can't be. I'm sure it's going to come back because we don't fix neck pain with surgery. That's what I was taught. That's the prevailing belief around the world. Even today, you can't fix neck pain or back pain with surgery. But the reality is their pain went away. And I couldn't understand why their pain went away, but it did. And then I started to think about it after, 40 or 50 surgeries where I consistently got rid of their pain in their neck and back. And I realized what I was doing different than what everybody else was doing. I was using a laser, but I was also doing what's called the annular debridement, which is what I'm doing right now, by the way. And by doing the annular debridement of the posterior annular tear, I was able to cure the people's back pain and neck pain. And I realized there was a link between the annulus fibrosis, which is what I'm working on right now, been working on actually, and their symptoms of back and neck pain. And that's when I made the connection that it was the posterior annulus that is the source of discogenic back and neck pain. We published our first surgery technique in 2012. That was 11 years ago. It's in PubMed. It's called the Duke Laser Disc Repair. And we've been publishing since then, and we've been expanding the indications to other parts of the spine, like thoracic, and obviously having excellent success. And we've also developed a new technique for rhizotomy called the Duke Plasma Rhizotomy, which got me started on this whole tangent of discussion, because we're not going to be showing that to you today because we're too busy. We have 3 operating rooms here at Duke Spine, and typically we work out of one because we have our broadcast equipment in one, but the other operating rooms we never put broadcast equipment in because honestly we never expected to be broadcasting so much, but we're happy that we are. And so the other rooms are not equipped with broadcast equipment. We're done. So I'm going to show you. Check this out, folks. Lights on. Lights on here? Yeah. Can you guys see okay there, Henry? Turn that light on, please.
Yes, we can.
Turn that light on, please. So this is her face looking up at you, her chest here, her neck here. We did 1 4-millimeter incision, and I fixed 3 herniated discs, degenerated discs with that 1 incision. Okay? I'm going to take this tube out, and just take a look at this tube. Okay? This tube is quite literally, give me the measuring stick underneath on top of my finger. Other way. Hold it here. This tube, folks, is quite literally 4 millimeters wide. You guys see that?
Yes, we do.
Okay. No joke. 4 millimeters, 3 discs with a laser. No one else in the world can do that. I talked to Dr. Weiss, my mentor. I asked him for advice. How do we get more surgeons interested in this to help patients? And he gave me some great advice yesterday. He's 84 years old, still living in California, still teaching. He was the chairman at USC for 15, 16 years, and arguably the best chair and leader of the entire department ever had in neurosurgery, in my opinion. And he's the one who really stoked the fires of interest for me as a medical student at USC when I realized that I didn't want to be an orthopedic surgeon. I wanted to do something else. And he got me interested in neurosurgery and kept my interest and directed me and got me to where I am here today, helping people from around the world get out of pain. So type up your questions for me. I'm going to come answer them for you face to face. Let me show you the incision. Can you guys see this, Henry?
Yes, we can.
There it is. 4 millimeter incision. Just big enough to fit that tube. No bleeding. We had probably 5 drops of blood the whole surgery. and no fusion, no metal, no biologics, nothing unnatural, totally natural surgery, just helping her disc heal itself because the disc couldn't heal itself. It tried. It needed a little bit of help, and we gave it that help by doing an annular debridement. So she's going to go home in an hour. This is completely outpatient, no hospital involved, no implant company involved, and no insurance involved, just doctor-patient. That's it. So type up your questions. I'll be happy to answer them for you. Great job, team. Next surgery we will not broadcast, but the one after is a lumbar 3-level Duke laser disc repair. So you got to see a cervical. Next will be a lumbar in about an hour and a half. Thanks. Go to a testimonial.
Good morning, I'm Dr. Ara Duke-Majan, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir, Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg, and went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Duke laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder, down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Duke laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone?
Gone, completely gone.
Cured?
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor. And they possibly looked at like doing rods and pins and all that kind of good, the fusion and everything. So it just kind of...
Why didn't you want to do the fusion option?
Long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck, your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Duke Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday. And I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4 millimeter incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to Duke Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you
Safe
so much. I
travels
appreciate it.
to
Thank you so much. We will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, Safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. Good morning, I'm Dr. Dugmajian. It's December 9, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now in my back, and Dr. Dukes is going to fix it next week, so I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed. But you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, the doctor did. They did surgery on 3 different levels, and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
There's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three level fusion, I don't know how long that would be, but it's
it's
terrible.
about that long
Yeah.
for a 3-level fusion. And then of course you'll have swallowing trouble for months,
Not
and
good.
then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Duke laser disc repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know and my 10 younger brothers and sisters, if you're watching this, if you have back issues, you need to come see Dr. Duke, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his dukespine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these
Yeah.
surgeries,
Yeah.
and probably better than me.
Okay. Thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yeah.
All right. Well, I hope you enjoyed watching that testimonial as much as I did. Seeing patients get out of pain completely, cured of their neck pain and back pain, it's special, and not many surgeons in the world are capable of doing it. But it is a surgical solution. That is the only way. Neck and back pain is caused 97% of the time by a disc problem or a facet joint problem. And both of those treatments are surgical. Sure, there's lots of other things you can do, shots, medication, therapy, copper, bracelets. Literally, I've seen it all. I've been doing this 26 years, treating patients with chronic back and neck pain for 26 years. I've seen every treatment out there, ozone,
ultrasonic, you name it. None of it works as well as the Duke laser disc repair. None of it works as well as the Duke plasma rhizotomy. Just so you understand the difference, Duke laser disc repair takes away pain from the disc. No matter what is going on with the disc, whether it's degenerative disc, herniated disc, bulging disc, annular tear, protruding, extruding, slipped, you name it, a disc problem, that's the source of the pain. The Duke laser disc repair is the best treatment in the world. That's where we use a laser to go in and basically, if I take the disc out and show it to you, the back of the disc has a tear and the jelly from the center or nucleus is sticking in the tear. That's where all that neck and back pain comes from. I use a laser to target it. Endoscopically, I can find the tear with the scope, and I use a laser to clean the tear. It's all done arthroscopically, and Duke Spine Institute is the only place in the world doing it. We are the pioneers of this technology. We discovered it first. We published it first in 2012. We've been doing it for 16 years now. So we've been doing it since 2007? Okay. Look back here in the back of this disc. There's a little tear there. You see that red line there and there, the other side. Those are annular tears, folks. That's where the pain comes from. By the way, this model was created by me. It's called the Duke Spine model. All right. It's made by my friend in Canada, who's not my friend anymore, but he was my friend at one time. We're done. We did 3 discs on this lady. They were quite degenerated. She's had problems for 12 years, and she's going to go home in about 30 minutes. So this is an outpatient surgery. It was all done with a 4mm incision right here in the front of the neck on her left side. And I feel really good about the surgery. We got everything done we needed to. I expect her to do quite well. All right, let's take some questions.
Yes, this next question comes from Carlos Santana on YouTube.
Carlos Santana, I love your music.
That's what he says, Dear Dr. Duke, I saw your previous videos and you had mentioned that discs will take about a year to heal after the DLDR. As far as I understood, DLDR removes only the herniations.
Is that a question?
I think so, yeah.
Yeah, so DLDR does not remove only the herniation. I see what you're saying. All right, let me explain. The DLDR, the primary thing the Duke laser disc repair does is there's a tear right here, and that tear is full of crud. And the crud is not just the herniation from the center, called the nuclear fragments. It's not just the nuclear fragments in there, but it's scar tissue and inflammatory tissue. And so you have a combination of stuff in there, bone spur, scar tissue, inflammatory tissue, and herniated fragments. So when I said to you the other day, or whenever it was you're listening, I don't take your disc out. We're not removing your disc. We're not taking any of the normal disc out. We're only cleaning the tear, debridement of the tear, which means I'm removing scar tissue, inflammatory tissue, and any bone spurs or calcium deposits in there from that are abnormal, and herniated fragments. So those are what we're removing from the tear. Okay, and we also remove anything sticking out in the epidural space or foramen. Hopefully that clears up.
And the next question comes from Jay Mora, once more on YouTube.
Hello, Jay. Welcome to our live stream at Duke Spine.
They ask, when you enter the annulus with the instrument, doesn't that create a tear on the disc?
So the question was, when you enter the annulus with the instrument, well, we're talking about the dilator. If you remember in the surgery, we came in through the front of the disc, right? And I penetrated. If you look carefully, you'll see there are little lines here. Those lines are fibers. So the disc has fibers. If you took a safety pin right now and you push it through your clothing and poke it through, are you damaging the clothing? The answer is no. And the reason you're not damaging it is because you are spreading the fibers. Spreading the fibers. You're not cutting the fibers, you're spreading the fibers. Cutting would damage, spreading does not damage. Your body has fibers. Almost all of your tissues except your bone, except your skin, except your brain, it has fibers. And those fibers can be spread apart and put back together. You like that? All right, so we're not damaging anything. We're just spreading fibers apart. Over time, they come back together.
No worries. Next question comes from, or a comment comes from Canes25 on YouTube. And they said, Doc, I had my ulnar nerve surgery. He had to move the nerve secured in fascial sling.
Yeah.
Boy, I hope it works.
You had an ulnar nerve transposition is what we call it. Thanks for asking. Thank you, Henry. Yeah, so the ulnar nerve transposition, in my opinion, is never needed. Your surgeon does it because they get paid more money. Look up the difference between an ulnar nerve release at the elbow versus an ulnar nerve transposition. An ulnar nerve transposition pays a lot more money. So your surgeon did an ulnar nerve transposition, which created a fascial sling to hold the nerve out of place. I have never had to do that ever. And what I was taught in residency was that you only do an ulnar nerve transposition when you're during surgery, you bend the elbow and the ulnar nerve pops out of the fossa medially. And I test that on all my ulnar nerve releases. That never happens. I never done an ulnar nerve transposition. It just pays more money. That's why surgeons do it. But it's not better for you. It's worse for you. And here's why it's worse. Because when it doesn't work and another surgeon like me has to go back in and really unpinch the nerve, now I don't know where the nerve is. You can actually cut the nerve because some surgeon moved it and stuck it somewhere else in your arm, and who the fuck knows where it is. And when I go in there and I'm trying to find it in its normal place, I'm going to accidentally cut through the nerve trying to get there. So I'm sorry to be the bearer of bad news, but it just goes along with the theme that I tell every one of you. Just because you have a surgeon living near you doesn't mean you should go to them. There's too much corruption in the industry. These surgeons are doing things to benefit them and not you. You want the best care? Travel. Pack your bags. Get your ass over to Florida to the Duke Spine Institute. Avoid bad surgery and bad treatment. Get the best right here. You want to see Mickey Mouse? You go to Anaheim and Los Angeles. You go to Florida and Orlando. Those are the two places. Sure, they got Magic Kingdom in China now, but I wouldn't go there personally. Too dangerous. Point I'm trying to make is, if you want something special, you need to be willing to travel for it. And by the way, in case you didn't read the bulletin, spine surgery is special. It just, it's not popping a zit, all right? It's not removing a fungus off your toenail. It is your spine. That's where your nerves live. And people, doctors that do bad surgery, bad treatment, you, the patient, have to live with those results, not the doctor. I promise you. I've had some horrible, horrible outcomes in my patients, not recently, but when I was taking care of patients with brain tumors and strokes, and those are diseases that are out of control. The doctor cannot control them. Those patients do horrible, many of them, and they die. It's not my fault, it's the disease's fault. Point is, do you think these doctors lose an ounce of sleep over your misfortune when you're dying or stroke? Hell no. They go home and watch TV, they have a nice dinner, they drink a glass of wine, and they forget about you. So you are just a casualty of their treatment. If you want to continue being casualties, folks, keep going to these shitty doctors out there. You want the best care, you come to the Duke Spine. We actually have a conscience.
All right, next question comes from Carlos once more on YouTube. And they said, can the DLDR be combined with any other form of disc sealing, and do you think it could be provide synergistic effects in disc longevity if performed after DLDR?
Yeah, Carlos Santana. It's really interesting. I've listened to your music for years. Never did I think of you as a scientist, but you are correct. If we could find a way to get the disc to seal quicker, that would definitely be better. I have not found anything that would allow that. Now, there are products on the market called Disc Seal. They're horrible. They're garbage. Do not get them put in. They are catastrophes, okay? All Disc Seal is this. Some guy says, let me create something that can act as a barricade, or a barricade is another one, disc seal, barricade, whatever. They're like, okay, how can I make money? Let me create something that sounds really good. I don't care if it really works or doesn't work. What matters is that it sounds good, and that I can then go to the venture capital markets and I can look for investors, like stupid people, who would actually believe that this thing works without really knowing anything about spine surgery. And I'm going to get these venture capitalists to invest millions of dollars into my idea, my intellectual property, and I'm going to have them make me rich, but at the same time, I'm going to create a product and sell them a product that doesn't even work. Well, now you're talking about disc seal and barricade. In my opinion, they do not work. How do I know that? I've seen a lot of patients who get it done. They come here because they're still hurting. So, those existing products do not work in the year 2023. Is there a product that will work in the future? I think there is. As a matter of fact, I've been working on one for a while now. I just have to figure out how to get it through the FDA. It's already being patented, and it is not like the disc seal or barricade. It's different, okay? Do I have any proof it works? No, absolutely not. Would I sell a product to people and put it in their bodies if I know it doesn't work? 100% no. I'm an ethical surgeon. I do things that help people, not things that help me, my investors, the hospital, the implant companies. I don't give a shit about them. Why? Because I was brought up the right way. My father told me, prioritize the patient. That's all that matters, is how the patient does. So that is my philosophy. That is the philosophy of Duke Spine Institute. Duke Spine Institute is my baby, my creation. So the people, the practices, the techniques, the treatments, everything we do here is based on one premise. Do what's best for the patient, period. Right?
Yes.
So because of that, we don't do garbage surgeries. We don't do many of the hundreds of surgeries out there that are available that hurt people, harm people, just for a profit. We will not do it, period. And maybe someday, 100 years from now, when I'm long gone, some corrupt person takes over my company and starts doing surgery and shit for people that doesn't work. I hope to God I come back and haunt them, because that is not what is the spirit of Duke Spine Institute. We are different because we put the patient first. We don't just say that, we actually do it. So, existing technology in 2023 that's FDA approved, marketable, there is nothing that you can put in that disc that is going to help it heal faster. However, I'm working on it. Now that I've got a few other projects behind me, this is something that's taken some of my attention. So, keep making great music and keep sending us great ideas.
Next question comes from Darren Sanders on Facebook, and they asked, had a C4-C6 fusion 10 years ago. I have significant scoliosis. Can that be corrected? Is MS contraindicated?
All right, so thank you. Terrence, great question. So Terrence is talking about his spine and his neck. He's had a C4-556 fusion. He has a plate that's twice as long as this one, okay, bolted on his spine. He's saying, Doc, I've got scoliosis. So basically, his case, his spine is twisting and bending to the side. Can the Duke laser disc repair fix my scoliosis? No. The Duke laser disc repair does not fix scoliosis. The real question you want to ask me is this. Do I need my scoliosis fixed? The answer is no, you do not. Is my scoliosis causing my pain? 100% your scoliosis is not causing your pain. Do I need fusion surgery? No, you do not. What you need, sir, is to get rid of your pain. And the way you do that is by treating the source of the pain. And as I've said to you all before, there's two things that cause pain in the neck, besides a fracture or a tumor or an infection, which is obvious, by the way. You'll see it on the MRI. But if you don't have a fracture, tumor, infection, like 99.9999% of people out there, you're having pain from your disc or from your facet joint. If you're having pain from your disc, the Duke laser disc repair will fix that. If you're having pain from your facet joint, the Duke plasma rhizotomy will fix that. So we have one treatment for each problem, and it is the very best treatment in the world for each problem. So what you really need to be doing is you need to be getting a virtual consultation with me where I can figure out what's wrong with you. Yes?
Mrs. Lindsay, I'm gonna
Sorry. So anyway, you want to do a virtual consult, free MRI review, happy to do it, or you can do a paid one if you feel bad for us and want to give us some money. The paid consultation is dukespine.com/VC. Henry's going to put the link in right now. You click on it. You can pay $99 and get a nice consultation with me, or you can do the free one. I'm not going to tell you which one to do. The free one is at mri.dukespine.com. All right, you need an answer. You need to know where your pain's coming from. Next question.
Next question comes from Jay Mora, once more on YouTube, and they ask, as I mentioned, I am on federal workman's comp. I do physical labor. Does this mean that I will be on restrictions for a while, since it takes up to 12 months for the annular tears to heal?
So one of our viewers has said, hey, I'm on federal work comp, and I know that it takes time for the annulus to heal. You said 9 months to a year. Am I going to be on restrictions for 9 months to a year? The answer is yes. Dr. Berndez, you need me?
Yes.
Is it a quick question?
Yeah, super quick, yeah. So the patient, we're doing 14 isolated levels. I'm not going to give her a general, and the reason being she has studied meds throughout both lung fields, so we're trying my best to give her sedation, but she probably is a better candidate for an endotracheal tube. I'm just looking.
Whatever you want to do.
Okay.
Your call.
I'm going to sedate her because of the meds.
Whatever your call.
Okay.
Yep, thanks. Alrighty then. So, yeah, I think I answered that, right?
Yes, I believe so, and that is it for questions.
That's it. We have no more questions. Thank you. You've all been a great audience. Our next surgery is going to be non-broadcasted because we don't have broadcasting equipment in operating room number 2. We're going to flip-flop back and forth between 2 and 1 in interest of time and patient safety. So we will be back broadcasting with you all for a 3-level lumbar Duke laser disc repair. There's a patient with back pain, leg pain, and pinched nerves and herniated disc annular tear. We're going to go in and fix 3 discs with the laser. I think we have a thoracic today too.
I think so too.
As a matter of fact, we have a special treat. Today is a special day. We have cervical, we have lumbar, and we have a thoracic case. Our thoracic patient comes to us from North Carolina or South Carolina. Anyway, he has a single level thoracic disc herniation, T6-7. We're going to be performing a Duke laser disc repair on his thoracic spine. You're going to see history in the making. There's nobody else in the world that does endoscopic transforaminal thoracic surgery for painful discs. Have a nice day.
We just got a question right.
One more question right at the buzzer.
Right at the buzzer. This comes from Andrew Summers on Facebook, and they ask, pain between shoulder blades. MRI shows disc bulging in both C4-5, C5-6. Pain is right between the shoulder blades. How is this possible?
All right, so one of our viewers is saying, hey, I've got a herniated disc at C4-5, C5-6. I got pain between my shoulder blades. How is that possible? You are correct to wonder. Because the disc herniations are up here, your shoulder blades are down here. How does that happen? Well, first of all, number one, I don't even know that those 2 herniations are the cause of your pain in your shoulder blades. That's a big assumption. If I examined you over the internet virtually with our MRI review, I could tell you definitively if the pain is coming from those 2 disc herniations in your neck. But as of now, I cannot tell you that. You may have a second problem between your shoulder blades. But let's assume for one moment you have one problem. 2 herniated discs in your neck, nothing else going on. How do herniated discs in the neck cause shoulder blade pain? Very common problem. The way they do it is by irritation of the nerve roots. The nerve roots run behind the disc, as you can see in this diagram right here. Here is the disc, and here is your nerve root. So if there's a herniated disc going backwards, this is backwards, it's going to irritate or compress the nerve root. That refers down into your shoulder. So assuming your C4-5-5-6 disc herniations are the cause of your shoulder blade, which you're telling me they are, I don't know that. I don't necessarily agree with you. I would agree with you if I did a virtual consultation. Maybe. And you may have a second problem in your thoracic area. But let's assume that it is the herniated disc. It's because of referred pain. All right. Have a wonderful day, and hopefully we'll see you all again in about an hour or so for our next surgery, which is the Duke laser disc repair lumbar.